Welcome to the MRCPology channel for a quick review and understanding of the topic. Imagine a patient arrives in the emergency department with known asthma. They are wheezy, breathless, and using accessory muscles. The first danger is obvious: bronchoconstriction. But the real exam question is deeper. Are they still ventilating, or are they becoming tired and heading towards respiratory failure? Acute asthma exacerbation means acute worsening of airway inflammation and bronchoconstriction. This causes airflow obstruction, especially during expiration. Air gets in but cannot get out properly. That leads to dynamic hyperinflation, increased work of breathing, and eventually ventilatory failure if the respiratory muscles fatigue. To understand acute asthma, think in 4 boxes: trigger, airway narrowing, air trapping, and gas exchange failure. First, the trigger: a viral infection, allergen exposure, smoke, irritants, or poor adherence to inhaled treatment can activate airway inflammation. In many patients, this is Th2 and eosinophil driven, but it may also be irritant driven. The inflamed airway becomes swollen, produces mucus, and the bronchial smooth muscle constricts. So the airway lumen becomes narrow from 3 directions: mucosal edema, mucus plugging, and smooth muscle contraction. The result is reduced expiratory flow. This is why patients develop wheeze, prolonged expiration, and breathlessness. Now, the key mechanical problem: air trapping. Because expiration is impaired, the patient does not fully empty the lungs before the next breath. Breath after breath, air accumulates. This causes hyperinflation. The diaphragm becomes flattened and mechanically inefficient. The patient has to work harder just to move air. That is why you see tachypnea, accessory muscle use, and sometimes pulsus paradoxus. Next comes gas exchange. Blocked and narrowed airways create ventilation-perfusion mismatch. Some parts of the lung are perfused but poorly ventilated, so hypoxaemia develops. Early in an asthma attack, the patient usually hyperventilates, so carbon dioxide is low. This is why a normal carbon dioxide in severe asthma is not reassuring. It is dangerous. MRCP trap. In severe asthma, a normal or rising PaCO₂ means the patient is tiring, alveolar ventilation is falling, and ventilatory failure may be close. Now let us classify severity, because in real life and in exams, treatment follows severity. Moderate asthma is when the peak expiratory flow is more than 50 to 75% of best or predicted, oxygen saturation is at least 92%, speech is normal, respiratory rate is less than 25, and pulse is less than 110. The patient has airflow limitation, but ventilation is still broadly adequate. Acute severe asthma is present if any one of these features appears: peak flow, 33 to 50%, inability to complete sentences, respiratory rate 25 or more, or pulse 110 or more. The mechanism is worsening air trapping and dynamic hyperinflation. The patient is breathing faster because the work of breathing has increased, and the pulse rises due to sympathetic drive and hypoxaemia. Life-threatening asthma is more frightening. Any one of these features should worry you. Peak flow, less than 33%, oxygen saturation below 92%, silent chest, cyanosis, poor respiratory effort, arrhythmia, hypotension, exhaustion, or altered consciousness. The silent chest is a classic exam clue. It does not mean the patient is better. It means airflow is so critically reduced that there's not enough movement of air to generate a wheeze. Exhaustion and confusion are also red flags. They suggest hypoxaemia, rising carbon dioxide, or both. At this point, the patient may no longer be able to sustain the work of breathing. Near-fatal asthma means raised PaCO₂, or the need for mechanical ventilation with raised inflation pressures. The mechanism is respiratory muscle fatigue, leading to alveolar hypoventilation and carbon dioxide retention. Diagnosis is clinical, and treatment must not be delayed. In a real emergency, you assess and treat at the same time. Measure oxygen saturation, peak flow before and after bronchodilator if possible, respiratory rate, heart rate, speech, and mental state. Do an arterial blood gas if oxygen saturation is less than 92%, if there are life-threatening features, or if there is a poor response to initial treatment. The blood gas helps you detect hypoxaemia and, critically, carbon dioxide retention. A chest X-ray is not needed routinely. Consider it if you suspect pneumothorax, consolidation, or if ventilation is being considered. Do not let investigations delay bronchodilators, oxygen, and steroids. Now let us move to treatment. NICE NG244 directs acute asthma management to the BTS and SIGN acute asthma algorithm. In practice, classify objective severity first because patients can look deceptively well. For moderate asthma, give salbutamol through a spacer, 1 puff at a time, up to 10 puffs. This is often highly effective and avoids unnecessary nebulization. If response is poor, give nebulized salbutamol 5 milligrams, preferably oxygen-driven. Give oral prednisolone 40 to 50 milligrams and continue or increase usual asthma therapy. For acute severe asthma, give oxygen targeting saturations of 94 to 98%. Give nebulized salbutamol 5 milligrams and give systemic steroids, prednisolone 40 to 50 milligrams orally or hydrocortisone 100 milligrams intravenously if oral treatment is not suitable. Admit the patient if there is no response or if severe features persist. For life-threatening or near-fatal asthma, act immediately. This patient needs senior help and early intensive care involvement. Give oxygen, nebulized salbutamol 5 milligrams, nebulized ipratropium 0.5 milligrams, and systemic steroids. Check an arterial blood gas. Consider intravenous magnesium sulfate 1.2 to 2 grams over 20 minutes, especially if there is inadequate response to initial bronchodilator therapy. Repeat salbutamol every 15 to 30 minutes or use continuous nebulization if the patient is not improving. MRCP trap. Do not give sedatives. Sedation can reduce respiratory drive and worsen carbon dioxide retention in a patient who is already struggling to ventilate. The key practical approach is this: assess severity, give oxygen if severe or life-threatening, deliver bronchodilator quickly, give steroids early, look for carbon dioxide retention, and escalate early if the patient is tiring. Discharge should only happen when the patient is stable. Peak flow should be more than 75% of best or predicted. Inhaler technique must be checked. Oral steroids should be continued for at least 5 days. An inhaled steroid should be prescribed, and the patient should leave with a written asthma action plan. Arrange GP review within 2 working days and respiratory follow-up within 4 weeks if the patient was admitted. If you remember one thing, remember this: wheeze tells you there is airflow, but a silent chest tells you airflow is critically low. And in severe asthma, a normal carbon dioxide is not normal. It is a warning sign. Quick recall. A patient with acute asthma is unable to complete sentences, has a respiratory rate of 28, pulse 118, oxygen saturation 95%, and peak flow 45% of predicted. What severity is this, and what immediate treatment should be given? The answer is acute severe asthma. Give oxygen if needed to target 94 to 98%, nebulize salbutamol 5 milligrams, and systemic steroids with prednisolone 40 to 50 milligrams orally or hydrocortisone 100 milligrams intravenously. A patient with severe asthma initially had a low PaCO₂, but later becomes exhausted and the PaCO₂ is now normal. Why is this dangerous? The answer is that early asthma usually causes hypoxaemia from hyperventilation. A normal or rising PaCO₂ means respiratory muscle fatigue, reduced alveolar ventilation, and impending ventilatory failure. Do subscribe to the channel for further videos.